I'm interventional cardiologist in the Hospital Clinic of Barcelona and researcher in the biomedical research unit of this hospital. For the trial is the patients treated with intracoronary devices, they are at a higher risk of device-related events. So, from some years in behind, there was a revolution, a theory that if we can use a bioresorbable scaffold that disappears from the coronary artery, we can give support to the artery and treat the disease, and then left the artery without any device. And this will and sometimes overcome the issues of the current generation drug-eluting stents and adverse related events to these devices. So now in clinical, in the practice, there was the polymeric BRS, which disappeared from clinical practice because of thrombotic issues. And now there are the magnesium-based BRS, which was the device that we studied in the MAGSTEMI trial. The rationale of the study was that when the device is gone, if it disappeared, is bioreabsorbed by the artery, by the coronary artery. The artery will restore its vasomotion and the normal physiology of the artery. To remember the methodology, the MAGSTEMI trial, the original, the main paper was reported in 2019. So at EuroPCR, we reported a trial update of the 2 years outcomes. And it was a randomized clinical trial, the open label trial, that was a multi-center trial that was conducted at 11 centers in Spain. So the primary endpoint of the MAGSTEMI trial at 1 year was a surrogate endpoint, was not a clinical endpoint, was the vasomotion after the coronary injection of nitroglycerin at 1 year follow-up. And in the EuroPCR, we reported the 2 years clinical outcomes. So we also look at the clinical outcomes at 1 year and then yearly on up to 5 years. So we are reporting as this report primary endpoint or primary objectives, the device-related composite endpoint. You should remember that is cardiovascular death, is target vessel MI, and target lesion revascularization. And that's also we are analyzing in this report the components of the composite endpoints and also the stent thrombosis or device thrombosis related events. So for remember also a little bit the results from the main report of the MAGSTEMI trial. In 2019, we reported that in fact, patients treated with magnesium bioresorbable scaffold has a better vasomotion at 1 year follow-up. And it means that when we the coronary angiogram at 1 year follow-up and we inject nitroglycerin to these patients intracoronary, they have a huge vasodilation of the coronary artery. So there was a higher rate of vasodilation of the coronary artery. So there was a sort of restoration of the physiology of the artery and the vasomotion when it was compared to the comparator device that was a sirolimus eluting stent. Nevertheless, at 1 year, magnesium-based scaffolds were related to a higher rate of device oriented composite endpoint, mainly because there was a higher rate of target lesion revascularization at 1 year. So the main observation that we did at 2 years, which is what we are reporting in EuroPCR, is that at 2 years, this difference between the stents is maintained. So at 2 years, there's actually a difference in favor of sirolimus eluting stents in terms of device-related composite endpoints because there was a higher rate of TRR during the first year. But when we did the landmark analysis, when we analyzed the cases between 1 year and 2 years follow-up in this time period, there are no difference between the two devices in terms of device-oriented composite endpoints or target lesion revascularization. So actually, we look up to all the events, clinical events that I mentioned before, and there were no difference in any of these clinical endpoints. So between 1 year and 2 years follow-up between these two devices, the magnesium-based BRS and the sirolimus-eluting stents. There were no difference in terms of device composite-oriented endpoint. There were no difference in terms of patient-oriented composite endpoints. And there were no difference in any of the components of the composite endpoint. So there was no difference in mortality, there were no difference in any type of MI, and there were no difference in any revascularization. When we go to the device thrombosis rate, there also were no difference between 1 and 2 years. So this is the main findings. We have a higher rate at 1 year, but we have the same rate during the follow-up between 1 and 2 years. The conclusions that we can do, what we can get from this trial is that in an overall cohort of the patient in the entire follow-up, 2 years, this is the higher rate of device composite endpoints because of the higher rate of target lesion revascularization in the magnesium-based BRS when it compares to the sirolimus-eluting stents. However, we should highlight that between 1 year and 2 years follow-up, there is no signal of difference between these two devices. So these two devices, at least in this small sample size of patients, are comparable from a clinical point of view. If we take into account the device generation that we study in the MAGSTEMI trial, the potential advantages that a patient could get from this type of the device is the restoration of the coronary physiology. And also, if the device is completely bioabsorbed in the first year, then the risk of device-related adverse events such as target vessel-related myocardial infarction or device thrombosis virtually disappears. So you can recover physiology from the artery, and also you can reduce the rate of events after 1 year. The risk for the patients, or what we found that is potentially a background of this device, is that more or less 20 or 25% of the patients, so more 1 out of 4 patients, could have a target lesion revascularization due to device restenosis. So with the current device of magnesium, we're finding a higher rate of target lesion revascularization because of restenosis. And we have looked up in a sub-study of MAGSTEMI trial, and probably the recoil of the device and the collapse of the device is producing this type of events in some patients. My take-home messages is that correlate with the magnesium-based devices, we can recover or restore the physiology of the vessel, and this was shown in the primary endpoint of the MAGSTEMI trial. Unfortunately, we have to acknowledge that there was a higher rate of device related restenosis or TLR at 1 year. And nevertheless, I still believe that magnesium is a very interesting biomaterial for the stent the development, because there was a very low rate of device thrombosis, and there are very interesting preclinical work on the biomaterial of magnesium that is less thrombogenic when it's compared to polymeric bioresorbable scaffold or even to current regeneration eluting stents. So the take-home message is that we should move forward this technology, and actually the company that developed this stent is now studying the next generation of the device in the first-in-man trial, and we believe that with an increase on the radial force of the device and also in a prolongation of the duration of the device, of the bioresorbable life of the device, these disadvantages of higher restenotic rate could be overcome. So it could be an improve in the future for the future generation and the treatment of patients in the next years.